Dear participants in the conference, my friends, in reality I know many of you personally and we've been acquainted for quite some time. I am very glad that I see you, but also I'm glad that I see some new faces. As Oleg said at the beginning of the conference, we have to involve as many people into our community as possible to discuss the issues that are of concern to us. We will talk not only about health, but also about health in the context of HIV, of sexually transmitted diseases. We will talk about mental health and about services connected to the HIV treatment. I also want to hear the voice of the community to get to know what's being done, what has been done. We have Alexandra Strilecka, who is a family doctor and the national consultant of the World Health Organization, Mr. Andrei Bilets, who is a rather long-standing colleague of mine. He is an infectionist doctor and also works at the Center for Public Health. We will also be joined by Vasil, who will actually be the voice of the community today. We don't have him now. All right. Here is Vasil Malikov, the national expert on the issues of LGBT community and also the member of the Alliance of Public Health. I'd like to start with the fact that as UNAID, we've been always supportive of the development of the community, and one of the most important parts of our work is to make the voice of the community well heard and always resonant, especially where the human rights are concerned during the provision of medical services. This is a cornerstone for us, and we will always insist on the principle, nothing about us without us. This is the major principle that we should support. You know, there are several global goals that UNAID is pursuing, and there's one of the goals that is not being talked very often about. This is 000. So we shall talk not as much about 95, 95, 95, як as 000. Without zero discrimination, zero lethal results, we will never achieve our aims and goals. So my first question goes to the representative of the WHO, and it will be about the integration of mental health services and it's linked to the services of the treatment of HIV infection. From your point of view, from the WHO point of view, what are the most effective ways here? Thank you very much. Thank you for coming here and being with us. I'll just extrapolate on your thought about 95, 95, 95. These are our strategic goals, but we are living in a quite unique world now. We are living in the world where, as the member of the team of joint jurisdictions, I would say that quite a lot in this world can be diagnosed effectively and treated effectively. However, people continue to die. And we, of course, will have quite a discussion today about diseases and about treatment and around the LGBTIQ plus community as well. When I worked as a doctor, I thought that I couldn't find sufficiently efficient approaches to my patients, and I had an widely open gestalt in this, and I had to combine medicine and psychology in order to better work with patients when I was practicing. Let's talk about the mental health now. Please tell me, when were you for the last talking to the family doctor? Did they suggest that you go screening for concern and depression? Could you please show us red or yellow cards? Oh, this is very eloquent. Not a single person got the suggestion that they should undergo screening from the family doctor, even despite the fact that the state says that it is an approachable, accessible service. I hope that our photographer took the picture, and I think that we will then use this. Can you please again show us the red cards? This is our card to the family medicine. But this is about family doctors. We've been working for 2 or 3 years with clinics of family medicine in Ukraine, and our findings were the same. They do not make screenings on psychology and concern in Ukraine. However, this procedure takes only 2 or 3 minutes. And actually, you can conduct 5 to 7 screenings within a very concise time. Sometimes doctors tell us that they don't have enough time, but we will talk about how we can work with this as well. And we'll also think about what is the crisis now about the existing medical workers and how we can raise the quality of medical services. We also think that for the integration of mental health into medical services, the skills of motivational consulting are important. This is very important. It is quite complex because it requires a certain level of skill for fighting the stress, and people also assume some sort of attention and the focus of attention. The doctors, when we talk to them about this, they say that they often do not have time for emotional consulting, and WHO says that this problem is widespread in the world, and now they are conducting the redistribution of duties. We also pay attention to junior medical personnel. We also can talk about the efficient practice of telemedicine. When doctors are readdressing their patients, when this is a hard case and you actually conduct follow-up and then you see that the person has gone. Well, now I will stop here and we will come back to the integration issue, but now I will ask Andriy my colleague from the Center for Public Health, how realistic is the plan to introduce the multidisciplinary approach when treating people with HIV, how this corresponds to the state policy?
I just would like to say that multidisciplinary approach is not what is important just, but it is critical, taking into account the realities of today. And we see what are our patients, our clients, they come and ask how to improve their mental health. And also what my colleague was talking about, it's better to do it later than never, but 2022 was an important year. And in 2022, our primary link was already providing the assistance, that is the assistance of family doctors, and that's absolutely free of charge. And that is what the Ministry of Health is promoting. The partners are helping. There were some things which are to be improved because the beginning is not always easy, but talking about personnel, we have conducted certain trainings, and these were trainings in online and offline format. So this is still a question of personnel training, which we need to work on. Also, we understand that the patient, the client, could go not just to a family doctor, and that should be improved in all the approaches of medicine. We also would like, I also would like to mention the law of Ukraine in 2025 on the system of healthcare, and that's for the first time the law talks about mental health, about approaches to mental health. And once there is the law, and the law that has become effective in January 25, that means that based on the law, the regulations will be developed taking into account the recommendations of our partners, the partners from far, and other international and local partners. I also would like to mention, and maybe you've heard about it, that from the beginning of 2024, the centers of mental health started operating. That is at an initial phase, will still need to promote it and implement it, but the centers of mental health are being created in every region of Ukraine. We have the provision which was passed by the Ministry of Health in 2024, and that is the document which includes all the criteria. And now the Department of Mental Health is providing expert assistance to medical doctors, to military. Besides this package of medical guarantees for primary link, we do have such packages for secondary and tertiary link, and that's for specialized assistance when the patient goes not just to the family doctor, but to some specialist. And there's a package which is called mental and psychiatric support, and that is within the system of National Health Service of Ukraine. All the services, it says mental and psychiatric services, but the package includes all the comprehensive services. There are some separate programs on mental health. It's not always psychiatric topic. This package is very important, and on the website of the Health Service of Ukraine, there is a map where you can go, you can select the nearest institution, you can go there, get assistance that you need. If you understand that this is the component which is to be improved, like some hotline, then such things are to be improved. So the state implements all these things. Talking about mental health, we understand there are many things to be improved, but our partners, the Ministry of Health, hears that and we promote and implement it. It's a difficult way because it's just the beginning, but the quality of services will be, I'm sure, at a higher standard. Thank you, Andrei. Now back to the audience. Have you heard about these centers of mental health, which are being set up at the level of regions? Oh, I see that most of you heard about that. You go for assistance to these centers. Have you ever addressed them? Is it because you didn't have need in it? If you didn't need it, then green card. If it was just that this is just not for you, then red card. 50-50, okay. I'd like to emphasize one thing. Stigma and discrimination, these are two barriers which are difficult to overcome. Stigma and discrimination. It's not just about the HIV infection, not just about the drugs or social orientation, it's about the mental health. It's more about mental health than about anything else because people are afraid to go for mental or psychiatric assistance because of internal stigmatization. They do not understand that this is the assistance that they require and it's accessible. Now, my question is to Vasil, as the representative of the community. How do you believe it's happening in the community? How popular it is that people go for mental or psychiatric assistance? Does the community have a big demand in mental health services? Yes. In fact, yes, the microphone is important and the voice of community is also important. Talking from the experience of work with the community, because I'm not just coordinating the activity of Alliance Global in Kharkiv, I'm not just the expert of the national group, but I also work with the community. I provide advice on HIV prevention. We are not just talking about HIV prevention, but we are trying to understand what are the needs, what are the requests, and the request for psychosocial assistance is quite significant. And fortunately, we already have the experience of several years of cooperation with the humanitarian donors and programs that allow, based on the organization of the community, to provide the services of mental and psychological assistance. We have the specialist psychologists who are trained, and we understand that there is such a request and such a demand. People come, go there, and talking about statistical information, talking about the number of people who come to our organization. We understand that the humanitarian system of Ukraine starts reacting to that. Quite recently, we have created certain dashboard. It's similar to what exists in the medical system, where you can find all the specialists to efficiently refer the people to some specialist psychologists or to special programs, but there is a specialized just audience, and that is LGBTIQ plus community. So there is such a demand. Also, distressing results of the survey when we ask whether people from our communities were going for psychological assistance from the state medical system, we see now some negative answers. And basically, practically, this is, as it has been mentioned, and I agree that the stigma and the discrimination they do impact, but they are stronger in our communities when it comes to gender identity, because the person doesn't want to discuss it with the family doctor because they can start talking about the identity and the sexual orientation, and the person is not convinced to what extent this consultation will be sensitive to gender identity or sexual orientation. The people are afraid that there will be some non-understanding, and that is why people say that they don't have a need to do so, or they didn't go there, they didn't feel that they could do that. My question to audience is, when you go there, did you experience some language of stigma, of discrimination, or some negative attitude to you because of your gender identity? Red, yes, you experienced. Green, no. Give the microphone, please. That was because of the social orientation and gender identity, because of my gender, because I'm intersex. In medical language, it's the people with violation of the gender. Yes, I face, but what you enumerated. That's a very good comment. It's very important one. Could you please tell us, was it a family doctor or was it some specialist? It's important for me to know. With the family doctor, there is a danger that they refuse to provide any medical assistance. It's not just something that happened to me, but representatives of the community say that the family doctors, they do not want to sign the declaration with you. We are complicated patients and talking not in medical language. We are sort of naturally sick, ill from birth. And for example, osteoporosis, most people face it after 40, but very often in our category, it's the disease which starts from the birth, and that is why the family doctors refuse. But there is a practice when any doctor refuses to provide any medical assistance. They say that I first faced it in 2012, 2011, and that is when people, well, they were saying, how is that? It cannot happen that the doctor would refuse to provide medical assistance. But that was the case, and now we see such cases.
Hello, everybody. I work for the program of HIV prevention quite a lot of time. I was engaged with the community. I have been involved in the prevention program for 7 years now, and we have noticed the fact that doctors do not refuse to sign declaration. They do sign declarations and agreements. And of course, there's quite a lot of doctors in the regions who understand the situation, but we saw the trend that the doctors are not providing the services to the same level of quality that to other people. Let's say a trans person comes to have their X-ray or something, and we see that they're not being given enough attention and enough care. We've seen this more than once, and many people from the community complain that there are cases of prejudice treatment. I, for instance, before even I made a legal transition, I saw such attitude towards me, like, for instance, an otolaryngologist would tell me, "Are you from those?" And I was asking, "From those who? Do you mean a prostitute or an alcoholic?" And she was looking at me with disdain and saying that you're such a people. But then when I, for instance, affected the legal transition, you don't feel this and encounter this anymore, but the feeling and sort of resentment is still there. You have to do something with this because they go through a lot of trainings, and many people seem to be informed about this, even in the universities. And one doctor told me, "I had just one visit from such a person over 5 years. Do I have to study you or what?" Okay, you and then you, thank you very much. My personal experience about going to doctors, I didn't have any problems with family doctors. I'm a transgender bi, and although I was there before the operation and before hormones, he examined me. There were nothing unpleasant. However, later I was sent to a gynecologist, and the doctor was very aggressive, although this was a private clinic for which I paid quite a lot. And I think I got moral trauma. And she later has diagnosed me with diseases that I didn't have, and I had problems later. And she also asked me, "Why do you want to make this transition? You're a normal girl." But I said, "I just want to do this." And then she said, "Okay." And then she started to write different recipes, including the conclusion that I have to have my uterus removed. Your remark, please. Andrei, if you want to tell something, then use the mic. I'm a psychologist. I will talk in Russian, sorry. Yes, of course, we have a friendly discussion. I am collecting, assembling specialists all over the place. from my friends and acquaintances. This is a real quest to find people, medics, who are treating such patients in a normal, acceptable way. In many cases, or maybe in the majority of cases, the doctors are receiving patients, but they do everything in order for them not to come and visit those doctors again. So I think that I actually have to prepare the road map to tell which doctors can be friendly and forthcoming to people from the community. Thank you very much. We are coming to our next issue, and one of the major problems with people with HIV is to actually make people stay within the system of treatment. And of course, if they leave the system, this leads to the further spreading of the disease. But of course, what you said, a person who met disapproval or resentment or not high quality services, they leave the treatment and the observation system, and the danger of spreading the disease is growing. And also, what about the international programs in this relation? This is the question to Alexander from the WHO, and to Mr. Andriy, the question is, what does our state do in this respect? Thank you very much. You know, I want to give a feedback to some people from the previous discussion. I want to tell you that, as the research shows, regrettably, as of today, the barrier for the doctors to do away with stigmatizing is not the lack of knowledge, but the behavior among the population where health is concerned. And quite often, one thing to hamper from actual good behavior, acceptable behavior, is the lack of the representation of a good role model of LGBTIQ plus friendly doctor. It is very important, as Yulia showed us, to find people who can be ambassadors in this thing and can actually stimulate us to create and spread the friendly attitude from the doctors. Our field observations testify to the existing stigma among the doctors who are not only retaining this, but also spreading it. Up to 20% of doctors, mostly primary stage of doctors, they have, I would say, a certain stigmatizing attitude towards some groups of people. And of course, the most resented group of people are those who use substances, but other groups are also affected. What I want to say, as far as proven methods are concerned, we have mentioned today already that there's an internalized stigma, And then a person also expects that there will be stigmatizing behavior towards them. That's why WHO is very much in favor of the integration politic. If you know the place where you are being accepted and received, and where you receive certain services, for instance, also some psychological services, mental health services, you go there. There should be co-location of such services. Also, we were talking about the fact that people from the LGBTIQ plus community receive visual signs of disapproval. They have to see also whether there's, for instance, the rainbow flag there, or the very, very important is that people are equal in their access to the services, and the policy of the WHO of active interventions to overcome stigma should be supported and maintained. And now, Andriy, but let's give the floor to this person. Yes, of course, it is very right that you should take such friendly doctors to the public. But then, okay, what is the stimulus for them? We have, for instance, taught them, but what is the profit or use for them? Because doctors are very, very busy people. But what they will have as a result? When we were talking with the people from the prosecutor's office, we found some stimuli for them. When I was very young and I started, we used to do this. I don't know whether this is being done, because there's no live contact in order to stimulate people. We know some people who would want, but they don't have time, or they don't have material opportunity. What can we offer such doctors so that they become such ambassadors? It's just that many doctors just are afraid of being recorded or taking a photo in this respect. So you have to invent some motivation. Two remarks, Andriy, in response to what you said. Ambassadors are people who are doing advocacy, or what about the advocacy motivated from within? Well, I must say that an advocate of the human rights cannot be salaried for this. This is either I have or I don't have. About what we can offer the doctors, we can offer them points of the lasting professional development. But of course, there is a danger of the camera that is being shut off. We cannot provide for their communication with the community, and everything has to be done with the involvement of the community, otherwise it won't have any effect. My experience says that, well, I heard that very many trainings are being organized, but from my own experience, and I'm being involved into such trainings, I must tell you that they are very, very few. And the number of regions and the number of specialists, well, maybe once a year, you cannot say that this is many, or besides, you have to understand the flow of personnel. I totally agree with you when you say that you should not just develop the programs with the participation of the community. You should not limit yourself to formalized trainings. You should build a fruitful cooperation in situ between the organizations that represent the community and specific medical establishments who are prepared and want to engage in such cooperation. And of course, we have to look for support of humanitarian donors, which showed how this can be done in a mutually beneficial cooperation. Not just the community imposes its ideas, or doctors or departments, but we should seek partner relationship so that the medical establishment should treat LGBT people as patients, not saying that I have one person like you within 5 years. This is not true. We understand this. This is a possible way.
I'd like to give the floor to Andriy, then Nazar, and then I saw one more hand. Andriy. It's on trainings, motivations. Thank you, Julia. Yes, when we are talking about discrimination, it's something which is important for Ukraine, post-Soviet countries, and European countries. But if we look at that in general, and if we take stigmatization and discrimination 10 years ago and now, you can compare. Now the situation is much better. I represent the Department of prevention of HIV infection, and we see a lot of work was done in this direction. For example, this law of Ukraine, which was implemented back in 2024, and it was updated according to the recommendations of the World Health Organization, and it says that the state should provide to all the patients testing, treatment, and prevention of HIV infection, and that refers to citizens with passport and without passport. That is what's happening at the national level. Talking about training, yes, we see how people change. We see some stereotypes, how we cannot change this stereotype during one or two workshops. Last year we had 10 offline meetings and trainings to stimulate the experts in order to actively consider the issues of discrimination, stigmatization, and the doctors of the primary link were involved, the Center of Control and Prevention of Diseases, also on the site of the website of the Center of Public Health. There are some trainings which are on the HIV infection and prevention, and some of stigmatization and other things. We also cooperate with the experts who are involved into training campaigns. Why I'm talking about that? We do need trainings, stigma and discrimination. We need all the time remind about them, talking about the support and of the key and vulnerable groups. We were talking about multidisciplinary approach, integration of services, the support of people who live with HIV infection is somewhat more developed. People who live with the HIV infection, we have integrated them already. There are issues to be improved, but we do have psychologists, we do have social support. Our regulations describe the modern approaches for different key groups, and these are the groups of people who can provide sexual services for remuneration and some other. At the regulatory level, that's being worked on, and the social support, talking about social support, and the charity organizations and partners, their role is extremely important when it comes to providing comprehensive services to patients based on the basis of different centers. These are free of charge programs, and we are working in this direction. And I would like also to mention the support of the foundation, because this foundation also supports financially non-governmental sector in different directions, sex workers and others. This is the non-governmental sector which is also stimulated. There are questions about amounts of stimulation and financing. We are actively working with non-governmental sector because we see that we need to expand all these activities only in Kiev and in Dnipro. Our colleagues work actively and at the state level with the support of the Ministry of Public Health. We financially stimulate these issues. There's some improvement, but again, we still need to provide more trainings for social workers, trainings about the rights of the population, because we were offended by the doctor, by the nurse, and for that there are some hotlines where we need to talk about that. To change the situation, we need to change it together. And I believe that that will be addressed in other spheres, not just when it comes to HIV infection. And my request is to the audience, this roadmap, which we will create as the result of this conference, I would like to introduce the proposal of closer cooperation and involvement of communities when developing the training materials for the medical community, and the community is to be also involved into this. Do you support it? Yes, that we will include it into the roadmap. Nazar? Good afternoon, Nazar Tokat from Lviv and the Foundation Impulse Ukraine. It sounds well, but what we are talking about, this is about cities. Let's look at what's happening in towns, smaller towns, in villages. It's where the doctor is in a different cultural environment. Will he become the influencer who's talking about importance of tolerance, of equality? Probably not. When we met at one training with Yulia, I had some session which I was moderating, and when I said I'm Nazar Tokar and I'm an open gay, and you should have seen the eyes of the doctors. They forgot all the languages and they started asking very strange questions which were not to the topic. That means that they have never seen us in the regions. There are many representatives of LGBTIQ plus community. They cannot talk about themselves openly. I also recollected that I let's think about regions, about how we can train doctors there, because in the regions that is something dangerous for the representative of the community, the representative who lives with the infection, HIV infection. And honestly, I do not see any efficiency in online training. Yes, we'll put it also into the roadmap that we support only offline communication with representatives of the community. Please give the microphone to one more person. Well, I will try to remember what I wanted to talk about. Talking about trainings for the doctors, organization, partner had many trainings, and they were called the underwater stones doctors. They invited family doctors, different specialists, the community representatives of community were there. I was at almost all of them. These were offline trainings. There are doctors who are interested in working with the community. They want to work. But then I will tell you why. But there are doctors who just came because they were told to. They came, they were there, and we had a group work. We work as a team. We write some algorithm of transition on a flip chart, and one asks me, have you written it? And I say, come on. And she addresses me as a man, but I am a woman. And talking about regions, there were multidisciplinary teams. In Dnipro, we have psychiatric doctors and different family doctors who work with trans people, transgender people, without any problem. They're interested because organizations refer people to them. The person is referred to endocrinologist and he charges money for that, and that's their motivation. They mostly all work in the private clinics. They go to psychiatric specialists or to get the special certificate, which now in wartime become very expensive. In some regions they cost $500, but those who want to get such a certificate, they get it. As to other specialists, the situation is not as good there. For example, for trans men to go to gynecologists, and we can, there are very few gynecologists who could cope with that, who could work. Now we are switching to KK11. And the question is, who will be working on that? Sexopathologists, sexologists, because now psychiatric doctor diagnoses what will happen later. We will need to organize trainings for sexologists. What I wanted to say that the motivation, those people who are interested in working with the community, they're interested financially. People come to them and they charge money for that. And I wanted to ask a question on prevention of HIV. The situation is when they find the positive status, the center is referred to the special center, and when the person is introduced into this system, there's no code TG. There are SP, there are other codes, people who use drugs And these people are put into that center differently. There's no statistical information in this system, even though trans people are included into the key group on HIV. Will anything be done with that or not? That's what I wanted to ask.
I think that Andrei will answer, but from my side, I tell you that this work is being done. I'm very glad that trans people were recognized by the state, and I was the member of the working group. We got so much resistance from different sides, even from some people from the Ministry for Public Health. But in the final count, we succeeded. And now about the code. Of course, this is the protocol that has not been changed since 2010 or maybe even 2009. It is being reviewed now, and it will be reviewed because it became clear that it is not just outdated, it should be changed and amended. They're working on this. Yes, thank you, Yulia, for the information. I want to add something to what the colleague said, that online webinars are still very important. I tell you that we are training not only urban doctors, but also people in doctors in the countryside. And almost 300 doctors were trained who come from the countryside. I would also like to thank people who are conducting those 3 days long trainings with the help of civil society, and they talk to people in different nooks of our state. This is a critical stage. This is the secondary stage, and there are also packages of medical guarantees. We have 16 packages of medical guarantees. They are also within the system. And of course, we are now working on the mechanisms of creating joint teams from the Ministry of Public Health and other departments about the quality of the provision of medical services by medical specialists. And this is going to be very topical. Multidisciplinary teams created on the basis of the regional AIDS centers, and I mean people from regional centers, from big hospitals. We are setting new tasks for them, and they go to different locations, they stage trainings there. This is very important, especially this year, because we made quite a lot of purchases. As a rule, we have different photos and documents as proof, and we can see that the number of subscribers to the information from the Center for Public Health has grown to 100,000, and we are working about this all in with the aim to lower the stigmatization. And of course, for almost a year, because of our new legislative base, we see that there are not just women and men, there are people who may consider themselves something different. And this is a separate category, specific category. We can find out the statistics and look at the fact that there are different people there. And of course, we are following this very closely. There's quite a lot of ballast that we have to work with as far as Resolution 171 is outdated. Of course, there's a draft to amend it and revamp it. This draft is in the final stage at the Ministry of Health, and there were many organizations and people that worked on this draft, including our public organizations and activists, but also state bodies as well. Well, I still is more inclined to share the opinion of our colleague from Dnipro. Before we have seen statistics, we don't see the entire picture. And this has to be a statutory collection of data. Andriy has touched upon the very important issue. When you were visiting any doctor for any particular reason, were you offered the HIV screening? No, just one person was lucky enough to get such proposition. Okay, a comment and then Vasil will speak. Well, my doctor has not suggested that I have such a screening because she knows that I work in the program where I can test myself. And by the way, about the psychological test, our family doctor suggested that I answer these questions, and he prescribed me gobelins. However, I'm a driver, and I understood that it would be dangerous for me to drive while I am on gobelins. But you know, for almost 4 years, I've been now under constant bombardment now, and I think that medical help would help me and also motivate me to work. However, it's a bit too expensive and a bit too time-consuming. Are there specialists that you can actually consult?
Можна? Да, добре. Власне, дякую, що дійсно
Thank you.
ми
We, as far as the community is concerned, we see that documents are being edited all the time. There are some very good documents about the HIV testing for every key group. However, we have to receive the data about what's the degree to which doctors, and not only those who belong to the former network of AIDS centers, because here the situation is more or less understandable. They are specialists who work with this. Yes, 16. and 36, not 30.
лікарі у своїй практиці
To which extent
використовують
the practicing
стандарти
doctors
допомоги ВЛНП,
apply
в тому
the
числі
standard of
лікарські
medical
випадки,
help
в яких
pertaining to
в
the
кабінетах
AIDS infection,
спецзв'язку
HIV
вже
infection.
не бачив. І тут я повертаюся до питання
And I'm coming
взаємодії,
back
того
now
всього, про
to
яке ви
the
тут сказали.
evaluation of
Стосовно
the
цього
quality of
діагностичного
services.
аспекту. Звісно, добре, що воно може
It,
проводитися
of
всередині
course, it
системи,
is good that it can be done within the medical system, and this is right.
моніторинг.
This is our internal monitoring, but you should not forget that the internationally recognized instrument is also the monitoring under the management of communities. And in this respect, they should embrace, well, we had the elements of such monitoring. We also talked about how financing influenced the services. So in reality, we are very grateful to you for being very grateful to the non-governmental sector. But don't forget that the non-governmental sector does not generate money. We only can use the resources provided by donors, and the donors' financing is not without boundaries. So I would like to attract your attention to the fact that the most stable and the most reliable resource for supporting the health of our communities within the sphere of services is the state and has to be the state, because I do hope that our state is interested in the whole range of services, including transgender identity and sexual identity, and we cannot talk about any evaluation of the quality of services without the people from the community who are on the receiving end of these services. And of course, it should also, this evaluation should also integrate the system of monitoring under the leadership of, supervised by the communities. And the state should support it, not only by saying that they are grateful, but also with resources. We have heard quite a lot, and we have a direct experience of communicating with the specialized medical establishments where infectionist leaders are working, and we can corroborate that the situation there, as far as the level of knowledge is concerned, is much better. But we also have to draw your attention to the much wider circle of specialists. And here it is also necessary that the communities should see and evaluate how these services are being provided. Because even from the elements that we were talking about, we understand that when you contact a doctor from the primary phase, and you have to address these doctors, because it is the primary level doctor who orders your, who issues the order for your order to a specialist. And they ask about this, and they are justified in asking about this. And they have to explain, for instance, to a doctor, what is the contact prevention. That's why it is not by accident that we are talking about the necessity for the entire medical system to be competent and prepared to the inclusion in order to work with our communities and our patients. And of course, if the doctor from the primary level does not know what everyone knows from the community, then why should we work with them?
I just would like to add a couple of things. I would like to say, talking about the situation when the person doesn't know where to go in the region, not in the regional center. That's very often happening. And what does this person do? He goes to the regional center to get a service further away from where such person lives. We have this process starting to differentiate between different levels of providing medical assistance. There are researches that show that from the moment when person starts working with a certain condition, then the situation changes. Then there is this problem. The World Health Organization talks about telemedicine for people who do not have any friendly provided services that they need. Talking about the situation that we saw in very often with the family doctor, when the contact with the doctor is so short that your doctor wouldn't know that his patient is part of this or that group. And World Health Organization suggests the approach based on indicator condition. And then they give you different things. These are the conditions which happen in life. How often does the doctor appoint the HIV test? Not always. And also we see that unfortunately the doctors, even infectionists, very often they do not know that there is such a type of prevention as pre-contact prevention. Post-contact prevention is as important as pre-contact, because post-contact is like the entrance to pre-contact prevention. The person who was in a risky group continues pre-contact prevention. There are several things. The one is on, please talk to the microphone, talking about involving the community. This should be improved. We are open for dialogue, and we very often have meetings with the Center of Public Health. We take these issues into account in our further work. This public health is working and we are open. So please come to us if you need. Talking about the monitoring, I agree when some specialist from the Center of Public Health arrives and everyone knows him, it's one thing, but it will be different when another colleague from a different community comes and assesses it. That is the work that has started. It's been lasting for more than 2 years. It's implemented by the Alliance of Public Health, and it's called the Secret Buyer. And soon I will have meetings with the medical institutions when no one knows this client. The list is being updated all the time. They assess whether the doctor had the information, who was observing it, was it the second person, what was the procedure. Uh, I didn't have a passport, for example, I didn't have medication, and this is what is being worked on. For the second year, we work on that, and these are individual meetings with the medical institutions. Then a different consultant is invited if we see that this visit doesn't give any result. Then we discuss it with the Department of Public Health, and our specialist of the Department of Prevention HIV infection are involved, and there is a special meeting when all doctors get together and others who provide similar services. We also have coordination councils where we discuss these issues. In some regions they do work, but we would like them to work everywhere. But for that, time is needed. Talking about integration of services, we have started work also at the level of primary medical assistance, where the services on pre-contact prevention could be received at about 20 points. And these are the places where they will provide these services. And one more thing is post-contact prevention. That is important because we see that the patients do not understand where to go. The doctor doesn't understand what is post-contact prevention. All the visits, well, we looked at the roots of the patient with post-contact prevention. Basically, before updating this route, we reviewed it with all the addresses, and this information is open, and it's on the map of the public health. And for example, if we take the year 2024, we had 1,500 post-contact preventions prescribed, and this year it's as of now already 1,800. But we need to apply a comprehensive approach to that. But we will take it into account. We understand that it is important to improve the cooperation with the community. Another small remark. As a person who was involved into the issue of developing the monitoring and the leadership of the community, we need to understand that this is a comprehensive approach. I heard, for example, about the secret client or the mechanism of complaints, but we shouldn't refer only to one or two methodologies, because these clients, well, we can show the desirable picture to them. If a person comes for the services, for services of testing, then when no one comes to you, but as to the complaints, and that especially refers to not just key groups who come for services of testing and prevention, but also people from our communities who have HIV positive status, for them this mechanism is very much limited. You mentioned that the network is getting expanded, the network that could provide services, but in many places of the region, there's no alternative. The person is afraid to complain, even at the level of the institution, or is afraid to complain to some hotline. Because this way, for this person, the most important thing is to receive antiretrovirus therapy. And the person is afraid that if they complain about some violations, then receiving the therapy could be doubted. So you cannot refer to just one or two mechanisms to understand the situation. The approach should be comprehensive and integral to assessment of services. Thank you. One more remark. I forgot. I agree with you, but you mentioned the national line. Don't be afraid to go to hotline because they don't register your name and the data is not transferred. We now work with the hotline, TB hotline, and we give some information on services which provide testing. We have some units which are responsible for prevention of stigma, and we develop the request, but we never register name or the last name. Well, thank you for talking about that. I believe that we'll be improving this direction of work. It's not like tomorrow we have to do it perfectly, and then we will achieve this wonderful future, because that's a process. The process is lengthy, difficult, and probably the most difficult thing is to change stereotypes, because the stereotypes is what person is growing up with. Doctors and medical workers are regular people like we are, and they live in their associate, which is limited by their bubble, and we are limited in communication, we are limited in our views. I agree with Nazar that the rural or regional medicine requires special attention. We always concentrate attention on large cities. It's good to work in large cities, especially when the population is more than 500,000, because the issue of stigma and discrimination is not that acute. People tolerate each other because they live in large society. We have 2 minutes left, and I would like to listen to your remarks. I didn't expect that we'll have so many people. I thought there will be like 70 people, not more. Thank you for active participation. And the monitoring should be independent. It should be mandatory independent. It should be the state monitoring. The state could not control this process, because this should be parallel independent processes. If the state controls it and sets the indicators, what we have to control, what we don't have to control, then the quality of monitoring will become doubtful. That's my understanding. Yulia, maybe you will add anything to what I forgot your name, to what Natalia said. Sorry. And that's on appointing the treatment that she received how can you go to a more friendly doctor or psychologist, or how can you get some advice, you as a practitioner?
А у вас вже й немає часу. Одне речення.
Just one sentence. We suggest to join our groups to get individual consultations. That's what we can suggest. It's difficult for me to switch to Ukrainian. Everything's decided individually. When the person comes to us, we make the roadmap. We do have the specialists in less than a minute. Thank you. Especially while talking about the present day. We are talking about LGBTIQ plus community. Well, next day, I would like to announce USDN will have a separate section which will be on trauma and sexual violence related to the conflict, war conflict. This will be a separate session. It will be a very interesting session. I had a scenario for today, failed after the second question, and I'm happy that it failed because our session was a free dialogue. And I'm happy that it was a free dialogue, and if I request you to come here for group photo, those people who were in this session